Hello, this is Dr. Alexander Haskell, and I'd like to speak about chronic fatigue and how over the last 35 years of practice I am seeing this really an epidemic in chronic disease, and most people also complain of chronic fatigue. No matter what their other physical symptoms are, they almost always complain that they're fatigued. So this is going to be educational, but also hopefully empowering for you to understand how to work with the medical system, and you can understand what the causes of chronic fatigue are, and hopefully find a physician who can be in agreement with you once you understand these underlying causes. So I tend to see the chronic fatigue or symptoms of chronic fatigue as being sort of above the surface, and below the surface would be what are causing the symptoms. So the medical system doesn't really investigate these underlying causes. They're basing their approach or their ways of treating chronic fatigue with primarily prescriptions, which is not going to be really beneficial for treating symptoms or the cause of symptoms. So if we look at the human being as body parts, so to speak, I don't like the idea of separating the soul or spirit from the physical body, but that's what we're going to be talking about today. The question is, in which organs does this fatigue reside in? And it's really all of them when it comes to something like chronic fatigue. So we could see the body is made of trillions and trillions of cells, and these cells make up various tissues, and the tissues make up glands, and the glands also are considered part of our organ system. So we must, when it comes to chronic fatigue, we must be thinking on the cellular level. And inside cells, we have a miraculous arrangement of different parts of the cell, but the one we'll be focusing on today would be the mitochondria. So mitochondria inside our cells, and there are hundreds of thousands of mitochondria in a single cell. And these mitochondria make energy, what's referred to as ATP, and this powers the function of the cell. Whatever that cell's function is, the ATP will drive that cell to function optimally. But what happens if the function of these mitochondria decline? So if it's a thyroid gland and there's lowered mitochondrial function and therefore lowered ATP production, you're going to have low thyroid hormones, which is going to result in fatigue, but many, many other physical symptoms will be experienced with low thyroid hormones. If it's muscle cells, there's going to be muscle weakness, fatigue of muscles, etc. If it's the brain, it's going to be brain fog, memory issues. With reproductive system for women, this is going to be ovarian dysfunction, etc. Low sex hormone production, insomnia, migraines, infertility. So the question then is, what are the causes of this lowered mitochondrial function? And the first cause, there's three causes. The first cause is nutritional deficiencies. Obviously, if our cells are not getting the nutrients they require, then of course there's going to be a lowered function, which is going to be expressed primarily through this lowered ATP energy production by the mitochondria. But also nutritional deficiencies can be caused by not digesting our food completely. Second is our exposure to toxins in our environment. A lot of this comes from the different chemicals that we're using in our home and workplace. Also, if you're a person that's taking over-the-counter or other types of synthetic prescriptions, these will also contribute to the residues of toxins inside the body. And of course, other external, outside our home toxins in the air and the water, etc. So these toxins get into our bloodstream. They then enter into our lymphatic system, the fluid that surrounds our cells. And also these are eventually compartmentalized inside of our cells, which leads to mitochondrial dysfunction. Third cause is low-grade chronic infections, and these can be a whole host of different types of bacteria, of course viruses and molds, and all of these give off their toxic waste, biotoxins, which also enter into our circulatory system, lymphatic, and the residues are finally compartmentalized in our cells. So we have three primary causes of mitochondrial dysfunction: nutritional deficiencies, these residues from chemicals in our environment, and the biotoxins produced by these various bacteria, mold, and viruses. So when it comes to chronic fatigue, where to start? And what is our primary objective with resolving this fatigue must be to improve mitochondrial function. So let's talk about this nutritional deficiencies part again, so it's more clarity with this. Again, we must be eating foods that are high quality, that are nutrient dense. If we're eating foods which have been processed and refined, a lot of those nutrients that our cells, our body requires are no longer available. And then, of course, we have to make sure the digestive system is working well. And this is probably the most important thing, because the number of people that I see with chronic fatigue are telling me that they are eating great whole foods, organic foods, but it really comes down to the digestive system. So when we swallow food, it goes through the esophagus into the stomach. The stomach should be producing plenty of hydrochloric acid to break the food down. And this is really important for protein digestion and also mineral absorption. So there is a sphincter, a muscle below the stomach that separates the stomach from the first part of the small intestine, called the pyloric sphincter. That remains closed. It is sensing when to open. At what point is there plenty of hydrochloric acid in the stomach? If the food passed right through the stomach immediately, a lot of it would not be digested. That sphincter remains closed until it senses there's plenty of hydrochloric acid. And once that sphincter opens and allows the food to come down into that first section called the duodenum, that acidity triggers a hormone to be released called cholecystokinin. And that hormone triggers the gallbladder to excrete some bile, which travels down into the duodenum to emulsify or break down fats and cholesterol, etc. Cholecystokinin also triggers the pancreas to secrete its all-important enzymes, which are in sort of an alkalinizing fluid to neutralize the acidity of the food that's come from the stomach. Then the food travels down into the small intestine, hopefully fully broken down or digested. And that food and nutrients, the nutrients from that meal, must then pass through the lining of the small intestine to be absorbed into the body. And oftentimes there are issues with these little fingerlings, these little villi that maximize the length of the intestinal lining. But sometimes, and actually often, these small villi, there's situations in the small intestine which don't allow the full assimilation of nutrients from the gut. And this can be overgrowth of bacteria, fungus or candida from usually antibiotics, chemical and drug residues, even heavy metals can interfere with assimilation. Parasites in the intestinal tract, food allergies, which causes shrinking of these villi, so the overall square footage of the intestine, so to speak, is much less or compromised. And of course, gluten is becoming more of an issue, mostly because I think the quality of the grains that are grown here in the States, and also the use of GMO, is causing issues with gluten sensitivities. So there is, besides food and digestion and assimilation, cleaning up the gut, etc., there's a good product we recommend often called Mitochondrial, which is specifically designed with all the nutrients that the mitochondria require to function optimally. But you've got to work on nutrition, digestion, assimilation. Second cause, toxic chemicals. Again, primary exposures in our homes with all types of chemicals and different fabrics and mold, etc., that can be in our home. So I really encourage people to be using, as much as possible, toxic or chemical-free cleansers in the home, and also investigating the water that people are drinking, where it's coming from, what filtration system is used, etc. Also the food that people are ingesting with herbicides and pesticides, trying to avoid the GMO foods, of course trying to eat organic as much as possible, avoiding the ingestion of chemicals and drugs into the system, watching out for cosmetics, both what's applied around the mouth but also to the skin, because they're all absorbed through the skin into lymphatics and get into the bloodstream. And then fluoride is an issue, as probably most people know. So all these chemicals, again, are traveling through the blood. They will be compartmentalized inside of cells, and they cause the slow decline of mitochondrial function. Third cause is low-grade systemic infections. These would be, again, bacteria, viruses, mold, and parasites to some extent. So the bacteria that's in the blood the blood is supposed to be sterile. There should not be any organisms in the bloodstream. But they do appear. I've seen it the last 35 years, lots and lots of times that people have low-grade systemic infections. And these chronic infections have never completely been cleared, and they produce their toxins, etc. This can happen from a deep wound or surgery, how these bacteria get in, dental infections, infected root canals, and cavitations, which are a source of bacteria inside the bone. Viruses are numerous, and there's so many different avenues of entry. Mold is, we breathe in mold, it's in the air, usually in damp, dark places, basements, or if there's been a leak in the house, it gets behind the wall, and the spores can enter our body through the lungs. There's often sinus issues and lung respiratory problems. The mold will enter into the blood. The gallbladder seems to be the most affected organ in the body from mold, and usually there's gastrointestinal problems, nausea, headaches, etc. as a result. So how do we assess, how do we go about assessing chronic fatigue, what these underlying issues are? And often I'll ask the person, like, when did you start first having symptoms? And were they gradual or sudden? Asking about environment and nutrition, etc., that we've talked about before. And are there also localized symptoms, not just a general physical and mental fatigue? And are there underlying biochemical and hormonal imbalances? This is really, really important. And therefore, we have to evaluate this by doing labs. So this next section, I think, is really important because it's going to help you understand some biochemistry of how your body works. And I'll focus on a few highlights of what you need to know. And by the time we get through this section on labs, you may know more than your physician, which is my objective here, is to educate you to know why you might be having chronic fatigue. So let's get started. So the physicians these days are a person comes in with chronic fatigue and there's no sign of specific issues going on, like there's not necessarily any joint pains or rheumatoid arthritis, etc. This is just a general fatigued type patient. So they'll always run some labs. So they'll run, usually with fatigue, they'll run this hormone called thyroid stimulating hormone. I'll get into this in much more detail with thyroid hormones because it's so important to understand. They may run what's called a free T4, and you'll understand what that means in just a moment. They'll often run a lipid panel with cholesterol And if your cholesterol is elevated, they're going to give you a drug. This should be a fasting lab draw or blood draw for checking lipids and cholesterol. They'll probably run a complete blood count, which is a count of your red and white blood cells. They'll probably do a comprehensive metabolic panel, which is going to cover a lot of, there's probably 15 or 16 different results in this panel. It's going to cover kidneys and liver, etc. They'll probably ask for a fasting glucose, again, fasting for 12 hours before the blood is drawn. They may run a viral panel, but even if it comes back positive, they won't know what to do with it. And interpreting viral panels is very tricky. Then we usually run vitamin D, and they may run 2 antibodies looking for a thyroid condition called Hashimoto's. And that's pretty much it. Unless you have specific symptoms, as I mentioned before, arthritis, etc., this is probably pretty much the panel that they're going to run. So these results almost always come back normal. Okay, and I'll explain what that means in just a moment. This is very frustrating because the person is feeling awful, and the doctor says, well, everything looks fine to me. It must be, they'll say, this must be part of getting old. Maybe it's a virus that's caused this. Maybe it's just stress. And maybe it's psychologically based. Maybe you're just depressed. Okay? All right. So let's talk about labs for a moment. Very important. Let's say I think it was back in 1962, this was the first thyroid hormone test that came on for physicians. So what is normally done with getting lab what's called reference ranges is they'll take a population of people, maybe 100 people, and they'll draw blood from each of those people, and they will check for this TSH. And they'll find that most of the people are found in the top of this peak, and those that fall to the right have a higher TSH, and then those lower numbers would be a lower TSH. And then they'll snip off about 10 to 15% off both ends, and this will establish a reference range for TSH, which presently is about 0.45 to 4.5. So if you fall within this reference range, you're considered normal. You could have 0.446 and consider, your doc says everything's normal. So it's interesting how we tend to generalize in our population about what's normal. So TSH, this hormone is produced by a gland in the brain called the pituitary. And blood flows through the pituitary, and it's always sensing the levels of thyroid hormones. And it will respond. If it senses thyroid hormones are a bit on the low side, then the pituitary is going to secrete to increase the secretion of TSH. And I'll get into what TSH does to thyroid cells in just a moment. If thyroid hormones are elevated as they pass in the blood passing through the pituitary, thyroid hormones seem a little high, then the pituitary is going to slow down its secretion of this TSH. So if thyroid hormones are low, then TSH is going to go up. If thyroid hormones are high, then TSH should come down. But this is an important differential here because a lot of physicians don't think too much about this. So these are 2 types of hypothyroidism. One is primary and the other is secondary. With both types, thyroid hormones are low. With the primary type of what's called primary hypothyroidism, the TSH is elevated. Thyroid hormones are low, the pituitary is sensing they're low, and it's going to secrete more TSH to try to increase thyroid hormones. And this is often a nutrient deficiency, meaning the thyroid cells do not have the nutrients they require to secrete thyroid hormones. And this is why thyroid hormones are low and TSH is high. With secondary, the TSH is low. The thyroid cells are not being told by TSH to make more thyroid hormones. And this is a pituitary issue. And most docs don't kind of differentiate between these two. So let me show you what happens with a thyroid cell so you understand some important basics. On this thyroid cell, there is a receptor. And this is where TSH can bind onto the receptor. And the reaction of the cell is actually internally is to produce hydrogen peroxide. I'll explain what that why that is in just a moment. Also in the thyroid cell, we have what are called, and this is an abbreviation, N is for sodium, sodium iodide symports or symporters. And these are like openings that can open and close on the exterior of the thyroid cell. And when TSH kind of binds onto this symport, then it allows iodide to enter into the interior of the thyroid cell. But in order to make thyroid hormones, this iodide must be transformed into iodine. And this is a function of hydrogen peroxide to make that conversion. So iodide or potassium iodide is an essential nutrient for thyroid cells to be able to make thyroid hormones. There's other nutrients as well. Selenium, zinc, and iron are also necessary to make the primary thyroid hormone referred to as T4 or thyroxine. The 4 stands for 4 atoms of iodine on this hormone. It's the most abundant, it's the primary hormone secreted by thyroid cells, but it's not the most activating. The T4 needs to be converted to T3, and this requires an enzyme. And this enzyme, in part, is dependent upon a trace mineral and a hormone. Selenium is a trace mineral. The hormone is cortisol, produced by the adrenal glands. So as far as thyroid hormone lab testing, there are 4 tests to be done. The TSH, what's called the total T4, which I'll explain what that means, the free T4 and the free T3. So let's look at let's pretend this is a blood vessel, and inside the blood vessel is the circulating T4 and T3. Also in the blood vessel, in the bloodstream, there are proteins called thyroid binding globulin, and these are specific binding globulins for thyroid hormones. Both T4 and T3 bind to these hormones as if they're on a bus, like having a reserve of these hormones ready to become free. So we have T4 that's bound to TBG, and also some of the T4 is not bound and referred to as the free T4. The same is true for the T3 and free T3. So let's look at the total T4 and what that blood test represents. It tells us the total amount of T4 that's both bound to the TBG, thyroid binding globulin, and the T4 that's free. That's what the total T4 means. So both the free T4 and the free T3 are small enough to leave the bloodstream. All right? So back to this lab report again. So most docs order what's called a TSH, thyroid stimulating hormone, reflex to the free T4, meaning if the TSH falls in the normal range, then the free T4 is not checked, which is totally ridiculous. If you think back on the primary and secondary hypothyroidism, this doesn't make any sense, because if your TSH is way at the bottom of the reference range, then your thyroid hormones are going to be flatlined. Okay, so this is not the proper approach. And I know even endocrinologists who should know what they're doing do it this way. So some docs will check both the TSH and the free T4. If the TSH and the free T4 are in range, then you're told you're normal and you're frustrated. And so TSH only is worthless. You've got to do a free T4. They'll do it if you're lucky. And they hardly ever check for the free T3, which is the most important thyroid hormone. It's the most activating thyroid hormone that's converted from the T4. So why aren't docs checking free T3? Because they forgot the fact, here it is. This is a medical physiology book. It's used at the first year of medical school. In this book, and this is the most famous one, Guyton and Hall, in the book it talks about T3. It says, T3 is the molecule, meaning hormone, responsible for most of the tissue action of thyroid hormones. What does that mean? It means that T3 increases the metabolism, metabolic rate, or energy production of all of your cells. Ta-da. So low thyroid hormones equals chronic fatigue. And I would say it is especially true for the thyroid hormone of the free T3, since that's what activates the cell and activates the metabolic and mitochondrial production of ATP, or energy. Okay? So a doc who understands thyroid hormones is going to order those 4 thyroid hormones if they know what they're doing. Okay? So let's talk about the cell in terms of glucose, what this means. We covered thyroid hormones. That's probably the primary thing you've got to make sure that those are optimal. And by optimal, if you have your own lab report, you might even have your hormones done for you already. You might have a report at home. Don't look at the TSH. Look at the total T4, look at the free T4, and look at the free T3, and look at your results, and look at the reference range to the right of your results. In general, you can divide that reference range right down the middle, and that would be optimal. So you can assess this for yourself. Are my thyroid hormones optimal? And you might find that your free T4 is great, 1.35, but your free T3 is down below 3. So now you know you have a conversion problem. Okay, so I hope that was kind of clear. Let's look at glucose. Cells, besides various nutrients, cells require 2 things. One is oxygen, and the other is glucose. Okay, if you don't get any oxygen, it's death. If you don't get enough glucose, then you go into a coma. So those are 2 really important nutrients to think about when it comes to chronic fatigue. So we're talking here about eating foods that your body, through the digestive system, is going to break the food down, and eventually most foods, especially carbohydrates, but even proteins and fats, will eventually be converted to glucose. And that glucose has to get inside the cell. And it's assisted by a hormone produced in the pancreas called insulin. So insulin opens up the gate, and glucose gets into the cell to produce energy, basically. So if there's not enough insulin, then glucose can't get into the cell and result in chronic fatigue. So very, very low insulin and lack of delivery of glucose to cells is type 1 diabetes. Okay? So if glucose is high and insulin is trying to drive the glucose into the cell, but there's what's called insulin resistance, then the glucose can't get into the cell, and the glucose is going to stay elevated in the bloodstream. And this will lead to definitely chronic fatigue because of lack of glucose inside cells. Increased glucose in the blood can be, first stage would be prediabetes. And if it gets really high, then it's going to be type 2 diabetes. So we have a fasting glucose. This is a blood test, glucose testing. A fasting glucose, and that means, fasting means no food for 12 hours, no food or drink for 12 hours before the blood draw. Water is fine. So what we're trying to do here is see how well your body is able to come back into homeostasis of not having food. How is your body regulating and getting blood sugar to become even, and kind of to a baseline, and I'll explain what that means in a moment. So the lab's reference range for a fasting glucose is between 75 and 99 what's called milligrams per deciliter. Okay, so optimal would be about 85 to 90 for a fasting glucose. Then there's another really, really important blood test called hemoglobin A1C, or HA1C. And this is measuring the glucose that is attached to what's called the hemoglobin of the red blood cells. And because red cells their lifespan is about 3 months, we're able to get an average blood glucose over the past 3 months. This is really, really important. So you can have a high HA1C and you can have a low HA1C. Of course, you can have a normal HA1C, but a high HA1C means your blood glucose has been too high over the last 3 months, and doctors usually use this for determining if there's diabetes in a person. But you can also have too little glucose, which means that this person has been, over the last 3 months, been slipping into low blood sugar too often. So we have a fasting glucose and we have this HA1C. So again, optimal for fasting glucose is 85 to 90, and optimal for hemoglobin A1C is 5.4 to 5.6 as a percentage. If we convert this percentage into the same units as a fasting glucose, we have about 115 would be an ideal result for hemoglobin A1C. So if we have a fasting glucose of less than 70, this is pointing to hypoglycemia. If we have a fasting glucose above 100, we're looking at hyperglycemia, like prediabetes. If we have a hemoglobin A1C less than 5, this is hypoglycemic episodes, and greater than 5.9 is pointing towards hyperglycemia. But any of these abnormals is contributing to chronic fatigue, okay? So we've covered 2 labs pointing to possible underlying causes of chronic fatigue: hypothyroidism and hypoglycemia. To some extent hyperglycemia, but hypoglycemia I see more often. People not able to regulate their blood sugar all the way, primarily because of the foods they've been eating. So the question is then, how would you know which one it might be? Okay, the underlying cause of chronic fatigue will never be just one thing. It's always multiple causes. So here's another really important lab test to get done. It's the complete blood count, which is measuring red blood cells and white blood cells. Red blood cells, again, transport oxygen. If you have low red blood cells, we consider it anemic. If you have low hemoglobin being the protein inside the red blood cell that carries oxygen to tissues. So low red cell, low hemoglobin is going to have symptoms of chronic fatigue because you're not delivering oxygen to tissues. So here's an example of a red blood cell. So here, the smallest blood, where this oxygen transport or delivery of oxygen happens is in the smallest blood vessels called capillaries. So it goes from the heart, arterial system, capillaries, and then the venous system returns the blood to the heart. These capillaries are so narrow that the red cell actually has to fold to be able to fit through the capillary. And sometimes there's a rigidity of this red blood cell, so it does not have much flexibility. And this membrane is made of both cholesterol and phospholipids. So again, we're kind of back to that first cause of chronic fatigue, which is nutritional deficiencies. Okay. So then we're also dealing with diet, digestion, and assimilation as well with this nutritional deficiency problem. Okay, let's go on to cholesterol. This is really, really important because cholesterol has such a kind of a negative point of view about cholesterol and dangers, et cetera, which I really don't believe in. It has to do with the oxidized cholesterol, et cetera. So if you look at this is the molecule of cholesterol. And here it is in all these, below cholesterol, these are all considered steroid hormones. Okay, so here's progesterone, here's cortisol produced by the adrenals, here's testosterone, and here's one of the estrogens. These are all steroid hormones. And what this is showing you is that cholesterol is the precursor, that the glands that make these hormones require cholesterol to make them, okay? So look at this sort of pink area, this steroid nucleus. And here is estradiol. You can see the same 3 hexagons and 1 pentagon. This same nucleus of the cholesterol is required to make estradiol. So low cholesterol means your steroid hormone is going to be suboptimal. And here's cortisol. There's the 4 parts of that steroid nucleus from cholesterol as well. So lipid blood panel test is really important, and how you interpret it is even more important. So you want to look at your total cholesterol, and a reference range on lab is going to be between 140 and 200 milligrams per deciliter. Optimal, I found, is about 185 to 190. Health issues related to all these steroid hormones starting to decline, including cortisol. Health issues begin, what I found is less than 150. And statins, most people are down to 120 and below. So these people on statins are, everyone eventually becomes fatigued chronically. So causes of decreased cholesterol, okay? Of course, statin drugs will lower cholesterol. Nutrition, not getting enough cholesterol in your diet, and absorption. And that has to do with, let's see if I got a slide here. So here we have this, this is how we assimilate cholesterol and other essential fats. So again, the stomach should produce plenty of hydrochloric acid, which that acidity will cause the cholecystokinin, that hormone, to tell your gallbladder to secrete bile, which travels through what's called the common bile duct, and finally empties in the duodenum. So that any fats or cholesterol, they are large globules of fats which can never fit through the intestinal lining and get into the body. The bile's function is primarily to emulsify or break down these large globules into little tiny micelles so they can fit through the intestinal lining and get into the circulation. So digestion can be one reason for low cholesterol. Okay, let's talk about cortisol. Really, really important hormone produced by the adrenals. So we're going to talk about blood testing first. So the adrenal glands sit on top of the kidneys. ACTH, adrenocorticotropic hormone, is produced by that pituitary gland and tells the adrenals to make cortisol. Just like the pituitary produces TSH to tell the thyroid cells to make thyroid hormones, this hormone, it drives or tells the adrenal glands to make cortisol. So in the blood vessel, bloodstream, in the circulation, cortisol travels through it. It's either bound to a protein carrier called transcortin, or it is free, off the bus, so to speak. Blood testing tests both the bound cortisol and the free cortisol. This is one disadvantage of doing a lab test, because you have no idea how much of the cortisol is actually free to leave the bloodstream and interact and react with tissues. This is total cortisol, both bound and free. We want to know free cortisol, much, much more important. So when you have your blood drawn for testing cortisol, just the stick of the needle through the skin into the blood vessel is enough to increase ACTH and cortisol, which is going to give the physician a very inaccurate idea about your body's flow of cortisol in a resting state. So it's a little bit of an archaic way of doing it. So let's talk about saliva testing. Again, we're back to cortisol being both bound and free. And we want to know the free. So the free leaves the bloodstream on its own. It travels through lymph fluid on its way to entering a cell. This lymph fluid is saliva. So if we can do a saliva cortisol test, we can know the free cortisol, which I have found to be much more accurate than a blood test. So let's look at the kind of the different disadvantages of both blood testing and saliva testing. Blood testing for cortisol is a single blood draw at that particular moment in time. Saliva testing, you collect 4 samples of saliva, and each of those samples is tested for cortisol. Therefore, you can have an idea, since you're collecting one sample in the morning, one at noon, one afternoon, one in the evening, have an idea where the cortisol levels are throughout the day. There's a stress of the stick for the blood draw, which is going to elevate cortisol. Collecting saliva is very relaxed. You'll probably get a much better idea of generally how the person is, how the adrenals are doing in secreting cortisol through the day. This gives us a single result. This gives us 4 results. This will give us a total cortisol, and the saliva is free cortisol. The results are usually off the next day, 1 or 2 days. That's an advantage, but I'd rather wait for results after 5 to 7 business days and be much more accurate with my assessment as to how much low cortisol may be contributing to a person's chronic fatigue. Okay, question is, what are some of the causes of low cortisol or adrenal fatigue? Probably uppermost is going to be insomnia. This is a time of night. This is a time when the body has a chance to recover and recuperate for having nice optimal levels of cortisol the following morning. Chronic infections, because of the biotoxins being produced by these infections, it puts a stress on the adrenals because cortisol is part of the engagement of the immune system to fight infections. But eventually, if the infection doesn't go away, eventually there'll be adrenal exhaustion. Chronic pain, inflammation is exhausting in itself. Cortisol is the body's own natural anti-inflammatory. And if the inflammation is chronic, the adrenals just can't make more cortisol to reduce the pain inflammation. And of course, a diet that's low in cholesterol is going to eventually lead to low cortisol, since cholesterol is required by the adrenals to make cortisol. Hypoglycemia, continuously diving into low blood sugar, is going to stress out the adrenals. Because when glucose starts going down, the body goes into a fight or flight. Eat something. The body's saying, eat, I'm hungry, feed me, but the person is too busy. They've been drinking a lot of coffee, blood sugar is falling, stress reaction, cortisol is released. Cortisol liberates what's called glycogen to get the blood sugar to come back up again. So chronic hypoglycemia is going to eventually cause adrenal fatigue. Excess exercise. What happens when you're exercising? All the muscles in your body require glucose besides oxygen, glucose. And if you keep exercising, pushing yourself, the body has to find a way of getting the glucose to come back up again, because the demand of all the muscles is going to produce cortisol to liberate glycogen again. And stress, chronic stress. Who doesn't have chronic stress? Okay. Sex hormones. These are really important. And estrogens, progesterone, testosterone, these also play a role with chronic fatigue. But it's very involved. And you'll see one of my books, a very presentation on sex hormones, but I can't get into that much detail, otherwise you guys are going to click me off. So here we go. So a summary of chronic fatigue. There are multiple causes of fatigue and multiple symptoms that can present. Sometimes it's just, I feel so tired, but often there's other systems, other organs in the body that are also fatigued and expressing themselves. So we know that these multiple causes can be nutritional deficiencies, environmental toxins, low-grade chronic infections. And with chronic fatigue, the doc that does the typical lab tests that I showed you before, they're all going to come back and you're going to be told that it's normal. And the good news, your test indicates that you're in the normal range. That's a great illustration of what's going on in the medical system these days. We are striving for optimal. We don't want to necessarily say we're in the normal range. We want to be optimal within that range. So here's some ideas for you. What is your next step? You need to find a physician, of course, but how? So some of the best ways of doing this is referral from a friend who's had a good experience from a clinician. You can try doing a Google search, maybe a chronic fatigue holistic doctor or something like that. And you can call the physician's office. If they're willing to speak to you, this is a really good sign, rather than saying just make an appointment with the doctor to speak with them. But oftentimes what I found, those conscientious doctors are actually speaking with a person that wants to schedule before an appointment is made. This is a good sign. First thing to do is, if you get a chance to speak with a physician, don't ask if they treat chronic fatigue. Everyone's going to say sure. So finding a physician, you must remember the causes of chronic fatigue, and then you'll know what questions to ask them, because it's about nutrition, toxins, infections, and sleep issues. So let's talk about thyroid. I think that's it. So we're going to cover again just questions to ask about thyroid, about blood sugar, about adrenal fatigue, and bacterial and viral infections. So the question is, what labs do you run for thyroid? Very simple question. The physician should be able to answer that for you pretty quickly. And if they say TSH, total T4, free T4, and free T3, this doc understands thyroid. And you might also ask, what thyroid medications, if I'm hypothyroid, what medications would you prescribe? And they'll often say, they might just say T4, but some may say levothyroxine. There are a few T4 prescriptions. And if they say T3, you might be on the right track. T3 is the liothyronine, another thyroid hormone prescription. But I think if they say desiccated, that's probably your best indication. Desiccated can be NP thyroid, nature thyroid, there's quite a few on the market, but that might be a green light for you. Next is, how do you check for hypoglycemia? And you know the answers, right? Fasting glucose, HA1C, to know your average blood sugar. HA1C is also known as glycosylated hemoglobin. How do you check for adrenal fatigue? They might say, I'll know by your symptoms, but maybe not. So if they say blood tests for cortisol, but if they say saliva testing for cortisol, that's a good match. And what if my fatigue is from a virus or bacteria? They may say, yeah, we do viral blood testing, but I've not found maybe not a thing with accuracy, but it's also how you interpret it. So that's kind of a difficult way of determining if the virus or the chronic fatigue is due to a virus. Unless a person has really a severe bacterial issue, like high temperature, almost like septicemia, there's no blood test to determine if the low-grade bacterial infection is the underlying cause of the chronic fatigue. Dark field microscopy is really the best way to know if there's an underlying infection. And also, you can also see, this is my monitor at the clinic, and this is showing what I see under the microscope. And those lines in the blood, that's mold. Okay, so mold, you can do a test with urine collection, looking for mycotoxins. But I found that the dark field is really a nice way and a fairly inexpensive way of determining if mold is an underlying cause. What about cholesterol and fatigue? Okay, this is the big question, because most docs are looking for high cholesterol and prescribing statins. But because you know now that low cholesterol in a fasting blood draw is going to equal to low steroid hormones and other issues as well. So if you want to learn more about our clinic, you can go to our website, clearhealthcenters.com. We're in Salt Lake City, Utah, and that's our phone number. And I'll fade out now. This last slide is last 4 slides are some books that I've written. So these are all found on Amazon. Heal Thyself, which is really an overview of natural medicine and the therapies and things that we do in our clinic. People really enjoy reading that book. I also wrote a book on the safe use of natural bioidentical hormone therapy, and wrote a book on fibromyalgia, and then a long time ago wrote a book for parents about how to treat their kids naturally with homeopathy and hydrotherapy and herbs, etc., supplements. So maybe we'll speak someday. All right, bye-bye.